Okay,
So
well, welcome everyone for joining our Health and Wellness Webinar Week. We are super excited to have City of Hope here today with Dr. Chu and Amanda, and we will also have Dr. Leach joining us soon. I am going to pass it over to Dr. Chu, and Dr. Chu, you can just let me know when you're ready to go to the next slide and I can hit next.
okay. Good morning, everyone. Thanks again for having me. Oh, I'm kind of stuck here. Oh, there we go. Okay. So good morning. Thank you so much for having me. If you have any questions, please feel free to ask us at the end. I think that's probably the easiest way to go. So next slide, please. So I wanted to share some good news about kind of why we're talking about breast cancer screening today. The good news is that people are surviving their cancer. So roughly 2/3 of anyone, and this is a little bit old statistics, but the numbers are so slightly better, but in this ballpark. So if you would be diagnosed with cancer today, chances are you have about a 2/3 chance that you will survive your cancer. That's the good news. That's regardless of what kind of cancer you have, that's the average. However, the reason we have an average like that is there's some cancers that we're doing really well on, and there's some that we're not doing as well. The good news is breast is one that we are doing quite well. And for most breast cancer patients that are diagnosed today, more than 90% will actually survive their cancer. And that's really because primarily screening and some of the advancements in treatment. Next slide, please. So breast cancer by the numbers in the United States, roughly 15% of all new cancers diagnosed are breast cancers. Skin cancer is still the #1 cancer though, regardless of your gender, regardless of your age, that's still the #1 cancer. So wear your sunscreen. But for women, really breast cancer is sort of the next highest cancer that they may get diagnosed with. So the estimated lifetime risk for all women, and this is just a woman with breasts, okay, in the United States, roughly 12% or 1 in 8 women, you probably have heard that statistic, roughly 1 in 8 women will be diagnosed with breast cancer at some point during her lifetime. So it's a disease that affects all of us, regardless of your history, regardless of any other factors. So the good news, of course, is that most of these women that are diagnosed will survive with their breast cancer. So that roughly in 2014, again, this is also still applies in 2021, over 3.5 million, now it's probably closer to 4 million or higher, women that are living with breast cancer in the United States. So we're surviving the cancer. But indeed, with appropriate treatment and hopefully early diagnosis, the survival rate for more than 5 years or longer is 90% or better for breast cancer. So it's definitely now become a survivable cancer, but a lot of it depends on screening. Next slide, please. So when we say roughly 1 in 8 women will develop breast cancer in her lifetime, that doesn't mean that you're going to be at risk for developing breast cancer when you're 8 years old. There's definitely an age-related factor. Age, in fact, is the #1 sort of risk factor, second to being a woman with breasts, is that as you get older, breast cancer risk goes up. So when you're young, it's actually pretty rare to develop breast cancer. And as you get older, that risk becomes higher, so that over a course of a lifetime, we're talking about 12%. But you can see the breakdown here. The older you get, the chances go up. This is per year. What is your risk per year that you could develop breast cancer? So again, you see as the age goes up, the risk goes up. Next slide, please. So really the most important thing is that if we can find the cancer early enough, then regardless of when it is diagnosed, we should be able to hopefully cure it. So the stage of the cancer does matter. Now, it doesn't matter anymore in terms of actual treatment. For the most part, whether you're stage 1, 2, or 3, the treatment is very similar. But certainly your chance at a full cure is much better when you're diagnosed at stage 1. The cure rate is greater than 90%, close to 100 these days, really. And with the subsequent stages, your survival rate will start to decrease. However, even if you're diagnosed by stage 3, which is when it has spread to the local lymph nodes, your survival and cure rate is still in the 80% or better category. So it's still worth getting diagnosed early. Next slide, please. So, the idea, of course, is that if we can diagnose it early and even maybe prevent it, your survival is much better. So when we talk about looking at things that we might be able to use to help identify your risk, these are the kinds of factors that we're looking at. There are factors that you cannot change. We've already mentioned your actual biological gender. So this is a little bit an older slide, so it's not quite as politically correct, obviously. But the idea is pointing out to the fact that biologically, if you're female and you have breasts and you're getting older, those are the top 3 factors for getting breast cancer. Men do get breast cancer, albeit at a much lower rate. If you have a family history, now everyone worries about their family history, but the reality is the majority of breast cancers do not have a family history. So if you don't have a family history, it does not mean that you're immune. Again, all women with breasts will have a 10% or higher risk of breast cancer, depending on these other factors. If you do have a family history, and we're not talking about great Aunt Matilda, who's 5 times removed from you having breast cancer, we're talking about either a significant number of people in your family with various types of cancer, or you have a disproportionate, meaning 2 or more female members of your family with breast cancer, then there may be a family history there with a particular gene syndrome that will increase your risk. And that's something that can be teased apart with a good history with your regular doctor or your breast specialist. We'll talk about some of those others later, but these are changes that you cannot affect. You can't affect your genetics. We can't change genetics yet. But there are things that we can change. And the big one up there is really smoking. So if you are a smoker, then the more you've smoked, the higher your risk potentially for breast cancer, as well as other types of disease and other types of cancers. If you were to quit smoking, that risk actually comes down. So it's worth quitting no matter what. Even if you're diagnosed with breast cancer and you're a smoker, if you quit smoking, your success rate at a cure also improves. So it's definitely worth stopping, even if you have a diagnosis or are worried about a diagnosis. And then some of those other ones, again, are technically modifiable, like getting pregnant or breastfeeding, but those are factors, obviously, in retrospect, things that you wouldn't necessarily change proactively. So the only other one I would mention that you can proactively change is body weight, and we're really specifically talking about body fat. So certainly women who are disproportionately higher in body fat do have a higher risk for breast cancer. So again, it's not about a number in terms of your weight, it's about your relative fat to muscle ratio that could influence that. So again, that's a relatively speaking something you can modify how much fat you have in your body. Next slide, please. But regardless of what your factors are, the bottom line is we need to find the cancer early, because those are not 100%. You can't cure breast cancer by prevention at this time, because even with all those factors being very low for you, the fact again that you're a woman with breasts is already going to put your risk at 10%. So even if your risk is 10%, there's still that risk of breast cancer. So the best way to figure out what to do with it is if we can identify it early. If we can identify the breast cancer early, your survival and your cure rate is very, very good. And so the key is, how do we screen for breast cancer? So there's really 3 ways that we really screen. The breast self-exam, meaning you examine yourself and identify any potential problems that way. A physical exam by a physician, whether that's your primary care doctor, your gynecologist, a breast specialist like me, somebody who's going to do a clinical breast exam can be very important in helping to identify early problems. And then some kind of imaging. Now, we're going to talk about what those options are for you and the sort of the good and bad about each option, but really imaging is the key, because the right imaging can find a cancer even before it's physically obvious, and we'd be able to cure it that much easier. Next slide, please. So what does a self-exam mean, and why do you do it? So for both a clinical breast exam, meaning one that's done by a physician or one that's done by yourself, the goal is to look for any kind of lumps, obviously in the breast that should not be there, as well as in the other physical changes that might signal a problem. Now, most women are going to have lumpy, bumpy breasts, especially if you're young and you're premenopausal. It is very common to have lumpy breasts. And that doesn't mean that they're all cancer. Most breast lumps are not cancer. They're either normal breast tissue that's basically very hyperactive and normally active, or some benign changes like breast cysts, which are little water bubbles, or little fiber balls or other fiber changes. These are all very common, and they're not cancer, and they don't increase your risk for cancer. So the goal is to distinguish a lump that's, quote, normal, or at least benign, non-cancerous, versus a lump that could potentially be a problem. And most of the time, that's a change that someone like me would be able to identify a little bit easier than someone who's doing it for themselves, because we know what are some signs that would be, sort of suspicious. And so if I see those signs, I'm more inclined to think that there may be an issue that we have to go after and further define. It's hard to explain what those might be to someone who's never felt them. And that's why the goal for your exam, if you were to do a self-exam, is really not to actually identify a problem. That's my job. Your job is to kind of get to know your breast, if you will, and understand what is normal. And that way, if you know something is different, that's an alert that you can give us. Next slide, please. So how do you do the self-exam? The self-exam should make it simple. Please don't make it hard, because the minute you start to make it hard, that's when you get discouraged from doing it. So I just want to give you some quick tips to make it easy. You only have to do this once a month. You don't have to do it every day. In fact, I discourage women from doing exams too often. Again, once a month is what we recommend. Most changes that are actually real and may be a problem are changes that are going to happen over the course of time. It's not going to happen overnight. And you want to make sure that you're able to register those changes. If you do your exam every day, you may not notice those subtle changes until it becomes much more obvious. So once a month is all you need. Pick a day that's easy to remember. And if you happen to be premenopausal, then make sure that you do it after your period ends, so your hormone levels are at their lowest. You can either stand up or lay down. Either way, you put your arm up above your head. It lifts and flattens the breast, so it makes it a little easier to examine. You basically just want to feel all the way around the whole breast, get to know them. Again, you're not looking for a problem. Just get to know them, know where your lumpiness are, if you have any. What does your breast look like? What do they feel like? You can do it in multiple ways. There's different ways that you can kind of check your breast and feel your breast. You can either go from the outside in circles until you get to the middle. You can go up and down or across. I personally prefer the compass or the wagon wheel, where you're basically going around the outside and going towards the nipple. I just like that because it gives us a little bit of a thinner breast to work with when you start from the outside and work your way in along those lines. But it doesn't really matter as long as you're consistent. So pick one that feels comfortable and stick with it. Next slide, please. So the physical exam then that you can do is very similar to what I would do in the exam, during a physical exam. The difference, of course, is, again, I'm looking for some very specific changes. And if I don't see them, the likelihood of there being a problem is much lower. Having said that, most breast cancers will not have a physical change in the very beginning when it's quite small. And so it's not going to be something that you're necessarily going to feel with your fingers. Most people are not going to be able to feel a real lump in their breast, like something that's actually abnormal, till it's about the size of a little almond or bigger. So if it's smaller than that, you may not feel it, and neither will I. My fingers are no more sensitive than anybody else's, although obviously I have a few more things that I know what to look for. But the idea is that there are limits to what our fingers can feel. And so, we really want to try to find it even earlier that, if possible. Now, there are some other subtle changes that can happen in the breast that we can pick up on exam. So again, that's why that physical exam with the doctor is important, because we're looking for those subtle signs. But for the most part, we want to catch the breast cancer before it's large enough for us to either feel or see a change in the breast or feel a change in the breast. And that's where screening comes in. And for the most part, the screening recommendations for breast cancer can become really, really complicated. And so this is just one sample of a screen where you can see each column stands for a different organization that has a recommendation for breast cancer screening. So most of us use either the U.S. Preventive Services Task Force, that's the government team that does recommendations for various types of health issues. The American Cancer Society is another one that very commonly we use their recommendations as a way to sort of get the message out to as many people as possible. But you can see there are other institutions that weigh in on what the appropriate screening is based on their particular area of specialty. So depending on which group, they may differ a little bit in terms of what their recommendations are. And also it differs depending on how old you are, because again, that risk goes up as you get older. So as you get older, there may be a little bit of a change in terms of how often should you screen. So this could become really, really complicated. And that's why sometimes you'll get different screening recommendations depending on who you talk to, whether it's your gynecologist or your regular doctor, et cetera. So let me simplify this for you. Next slide, please. If we're really going to distill it down and just really get the main important thing, this is what you should all remember, and what I would suggest that you think about for your screening. If you're older than 40, okay, 40 years old or greater, you should consider getting an annual screening mammogram. And so once a year, one mammogram, that's all you need. If if your risk is low, then you may be able to kind of modify that, but and maybe skip a year or two when you're in your 40s. But definitely by the time you're 50s, you definitely should think about that annual mammogram. So again, if you're over 40, I encourage you to start getting into the habit of doing an annual screening mammogram. If you're younger than 40, your risk for breast cancer is still so low that routine mammograms have not been shown to be very helpful. Especially, we'll talk about why the mammogram in the younger breast is sometimes harder to interpret anyway. So if you're younger than 40 years old, then talk it over with your primary care doctor or your gynecologist, because then it depends on your risk factors and whether or not those need to be considered in terms of when do you start screening. If you are considered quote unquote high risk, depending on what combination of risk factors you may have, then sometimes we'll add that annual MRI and we alternate it with the mammogram. And again, these are specialized screening recommendations, and you need to discuss that with your doctor. So over 40, get an annual mammogram. That's basically the message. Next paragraph. Next slide, please. So and I keep saying mammograms. Why do I keep saying mammograms? Because mammogram really has been the #1 test that we've used in recent years that have improved survival, as well as allowed us to really diagnose breast cancers early. In fact, mammography or annual mammograms have reduced the mortality or dying from breast cancer among among women from 40 to 74, especially for those who are actually 50 or older. So it has actually demonstrated that it saves lives. So yes, there are nuances, and you can read all sorts of nuances, but the bottom line is, since we started doing annual mammograms, women dying from breast cancer has significantly decreased. So we do pick up earlier cancers more frequently, but women are curable at that stage. So mammography is really the key. Now, ultrasound is helpful as an additional study, not as one by itself for screening for breast cancer. Because the problem with an ultrasound is that it just doesn't give us that overview of the breast that we really need to get an idea of what's happening in the whole breast, not just in specific sections. However, it is really helpful when we do feel lumps or see potential problems to have an ultrasound, because ultrasounds are really good when it comes to defining non-cancer lumps. So things like breast cysts or little water bubbles in your breast, as well as the majority of little fiber balls and fiber changes, can be really obvious on ultrasound. So they may look a little questionable on other tests, but an ultrasound may be enough to let us know that this is not going to be a problem and you don't need to have any additional testing. So that's where ultrasound can be a very good addition. The other thing that ultrasound does is that it allows us to do a biopsy a lot easier. So if you do have something that we're worried about and we need to know exactly what it is, then we need to get a piece of it to look at under the microscope. And using an ultrasound to help us do that, to make sure we get the right piece, can be very helpful as well. So ultrasound does have its role, but not as a screening tool by itself. Breast MRI is our third option, and it can be a really, really sensitive test, but there are some downsides. It's expensive, and it requires you to be in a very tight tunnel. So if you're at all claustrophobic, it can be a difficult test to do. And sometimes it is not available where you are. It's a much more difficult test to obtain because it's not as widespread. So there are limits to its use and its accessibility. Next slide, please. Let's do a little bit deeper dive into the mammogram, because I get this asked. I get asked this a lot. Mammogram is it really safe to have? Because it is, technically speaking, an X-ray based technology. So with each mammogram, you do get a little tiny bit of X-ray when you do it. But the reality is the amount of X-rays you're really getting with that concentrated just a few seconds to get the image is about the same as if you stood outside in the sun and unprotected without sunscreen for about an hour. I mean, it really is a pretty minimal amount of X-rays that you're getting with the mammogram, and it can show us so much. So please don't be afraid of it. Now, having said that, you don't want to get any more than you need, because you don't want to have any more X-rays than you need. But doing that once a year mammogram, really the amount of X-rays we're talking is minimal. But the issue that really comes up with mammogram is that sometimes the mammogram can be a little bit difficult to interpret. And then you end up having either additional mammograms or other tests for us to try to figure out what's going on. And the main reason, for most part, why the mammogram can sometimes be difficult to interpret is this whole idea of density. You know, how dense is your breast? And you're going to hear this if you, or read this in your report when you do a mammogram, the level of density in your breast. Why do we care? What denseness refers to is the amount of glandular tissue that you still have in your breast. Glandular tissue is the part that makes milk. So even if you're postmenopausal, no matter how old you are, you still have some of that tissue. It may not be very active. So you're not actively breastfeeding. It's not going to be very prominent in terms of producing milk, but the tissue itself is still there. Now, as we get older, that tissue tends to kind of go away because, again, we're not using it, but it doesn't mean that it has to. And so regardless of how old you are, you may still have a lot of that glandular tissue hanging around in your breast. And what happens is on a mammogram, as you can see from level 1 to level 4, you see those white streaks. And then level 4, you basically have sort of a white patches in your breast. That's the glandular tissue. The gray stuff is breast fat, which is what the majority of the breast is made of, is fat. But again, as you get as you are younger, you have more of that glandular tissue mixed in with the fat. As you get older, you get more just the fat shining through rather than glandular tissue. So if you're level 1, it means that you have mostly fat in your breast and very little of that glandular tissue left. As you can see, you can really clearly see little white lines, little spots. They're very easy to tell. If you still have a lot of that glandular tissue, let's look at level 4, you can see that it all kind of blends in together. It's all just sort of a white patch. Now trying to distinguish those little lines or little tiny white spots in there could be very difficult. That's the issue with mammogram. If your breast falls into the level 3 or level 4 category, your mammogram may be harder to interpret. And then we're going to be looking at those white spots going, gee, is that just another area of having a lot of breast tissue, or is there a problem in there that we're not seeing? Next slide, please. So this is where the 3D mammogram comes in. And some of you may have heard of that, if not all of you. This is a relatively new technology. So 3D mammogram, or breast tomosynthesis is the technical term, is basically the same as a regular mammogram or 2D mammogram. So the top 2 images, you see the 2D, which is your regular mammogram, and then one slice of a tomographic image. And what it's trying to show you is that there's a subtle difference in how the pictures look. In a 2D or regular mammogram, those of you who've had one, you know that it's basically a machine that squeezes your breast. It squeezes it vertically one way, and then it squeezes it horizontally in the other. And so what you get is basically 2 images. You get an image of your breast squished in the vertical plane, and then you get one that's squished in the horizontal plane. So everything's all squished together into those 2 pictures. While the tomosynthesis or 3D mammogram, as you can see on the bottom, is that rather than just doing one image, you're actually getting all these virtual slices through your breast. So it's basically kind of like a CAT scan. Those of you, again, who've had the CAT scan, it's these virtual slices through your breast rather than one image where everything is compressed. So what that allows us to do is we can actually pull out those individual slices and look just at a small piece of your breast, sort of a microscopic image of your breast almost, where you can just look at a very thin portion of the breast rather than all of it compressed together. So what the top image shows is that the exact same breast, one taken with a 2D image and one that's taken with a 3D mammogram, but just showing one slice. And the circle is supposed to show in that same area in the 2D, it's an area of whiteness. You wouldn't even see that little tiny star, that kind of a white star looking thing that you see on the tomosynthesis version. That is very hard to see in the 2D. So if you do have dense breasts, it's nice to be able to get a 3D mammogram if you can, because it allows us to be able to see those tiny differences a lot clearer. Now, if you don't have access to a 3D mammogram, a 2-dimensional mammogram is still better than not getting a mammogram at all. And we're talking subtle differences. For the most part, most women, the 2D mammogram is just as good as the 3D. You don't have to worry about it. But this is something to think about if you're told that you have dense breasts. Next slide, please. So one option that for women who have the dense breast, but that mammogram can sometimes be a little bit harder to interpret, is adding the ultrasound. Now, the traditional ultrasound is the handheld, which is shown on the left. It's a little wand that a technician waves over your breast, and it captures images, but it captures it a sliver at a time. It's just the width of that little handheld device. So it's hard to get an overview of the breast. That's why we don't use the ultrasound for screening. The new version is that it's something called an ABUS, or automated breast ultrasound. And it's a device that some places have. Again, this is a relatively new device, so a lot of places don't have this yet. But the idea is, rather than that little handheld device in a hand, you see the technician holding a paddle, a much bigger area that is then placed over your breast, and the computer scans everything under that paddle. So you can see how we can actually get a view of the entire breast in one shot. Next slide, please. And that's what you see in this image. In the standard ultrasound, you see a slice of the breast on the left. So a cancer may look like that. Just you're looking for that subtle difference, so that black area in the middle of all that grayness. So you're looking for a slice. But in the automated breast ultrasound version on the right, what you're seeing is actually the entire breast. And you see very clearly that there's an empty, that area of blackness, which is that, again, that same cancer seen in 3 dimensions. So we can really get a good picture of where that cancer is located and how it looks relative to the rest of the breast. But again, the point about the ABUS is not to find cancers, because ultrasound ultimately is not the best test when it comes to looking for cancer. It's really helping us to check for things that are non-cancer as a comparison. So if these are more like water bubbles, and especially if you have a lot of them, the ABUS is really nice because it points all of those out, and we can then tell which ones are ones that we need to investigate further and which ones we can ignore. So if you have access to an ABUS and you have a dense breast, that could be very nice addition to your mammogram. But just by itself, the ultrasound is not a good test for screening, and I would not recommend it as a standalone test. But in the right circumstance, it can be a really good companion. Next paragraph. Next slide, please. The MRI, like I said, is the last option in terms of imaging. It is a very, very good test for breast cancer, just like the mammogram. It also, kind of like the 3D mammograms, gives us multiple images, like you can see on the right, where we can actually slice through the breast, and we actually get both breasts in at the same time and look at them at the same time for comparison. So there are definitely advantages to an MRI. However, on the left, you can see how it's typically done. You have to lay on your stomach. Your breast kind of goes through either a hole in the bed or a little apparatus like what they show in this image, and then you're wheeled into this very tight tunnel, as you can see in the bottom image, and you have to stay in there completely motionless for about 20 minutes while everything kind of bangs and makes a lot of noise around you. In addition, you have to get a dye in your blood that allows us to see these images. And again, on the right side, you can see there's a image A versus image D. The reason that whiteness is there, that's to show that a particular dye was used to help us with imaging. So you have to have that dye. If you don't have the dye injected, then the MRI is pretty much useless, because it won't tell us the difference between normal tissue and possible problems. So you have to have a dye in your system, and you have to go through this type machine. So that can be a problem for some people, either because of the dye. Some people can be sensitive to it. Also, it is a chemical, although it is very safe. We've literally had MRIs now for decades, and this has not been shown to be a problem. Nevertheless, there's always a concern, is any kind of chemical potentially going to be a problem long term? So doing too many MRIs then makes us worry. Plus, we're not just talking about the breast. MRI is also used for other things for diagnosis, like if you hurt your shoulder and they want to make sure that there's no torn ligament or torn muscle, you might get an MRI there. You might get an MRI on your back if you have a lot of back pain, etc. So the problem is you may get multiple MRIs, and that means a dye every single time. So that could start to accumulate, and we worry about that. So the MRI can be a difficult test for some people for many different reasons, and that's why, for the most part, we do not recommend the MRI as a routine. There are times when the MRI is helpful, especially in a younger woman, where that mammogram can sometimes be a little harder to interpret. If there really is an issue that we cannot interpret appropriately, or worry that we're missing something, the MRI then can, again, be helpful as a secondary screen. And in some cases, it can be used as the only screen if you're a younger woman and we don't want to start your mammogram hopefully until after you're 40. So if you're younger than that, typically we start with the MRI rather than starting with the X-ray. So these are the options that we currently have for breast screening. Next slide, please. Now, hopefully, by using one of those studies, again, in particular the mammogram, because that is the most common, we're going to be able to identify your cancer early. The goal of identifying it early is not only that your survival is much better, your cure rates are much better. Like I said, at stage 1, a cure rate these days is probably close to 98, 99%. But it also allows us, if you have an early stage cancer, for us to be able to offer you treatment that are better for you in the long run. Because if you can survive your cancer, which we expect you to, we also want the rest of your life to hopefully be as good as the first part of your life before cancer, and that means physically as well. So for most breast cancers, if we catch it early enough, the first step is typically surgery. If we can just get rid of it in the breast, then the majority of the cancer is gone already. And then there's some things that we can do to hopefully keep it from coming back. But that's really the first step. Now, if the cancer is small, then we can usually save the breast. We don't have to remove the entire breast to treat breast cancer, especially if it's small and limited. So a lumpectomy or breast conservation is one that we do most often when cancers are found only on imaging first, no other physical signs. And now these days, we can even do not just take out the lump, but in the right hands, we can do a lot of things to make it look better. There are techniques that we can use to sort of manipulate the tissue, as you can see in the diagram, where it actually makes the breast look like you've never had anything done. We can still maintain the contour of the breast. Size sometimes can be a little bit difficult because obviously I can't put back what I took out, but I can certainly shape it. And a lot of times you can barely tell that the patient had any surgeries at all. We can hide the scar in many cases so that it's not noticeable. So again, cosmetically, you can get a much better result. And if you add radiation, which Dr. Leach is going to talk about a little bit more later, if you actually add radiation to this, then your cure rate is the same as if you had a mastectomy. So you can do a lumpectomy with radiation and you'll have just as good a cure rate. So you do not have to lose your breast and you'll be able to survive and live a great life, hopefully. Next slide, please. Now, even if you end up having to do a mastectomy because the tumor is a little bit larger, or if you choose to do a mastectomy, we can certainly do that. And again, the smaller the cancer, the better your options are. The standard or traditional is we remove the breast and we don't save anything. We don't save the skin and we don't save the nipple because there's breast tissue that goes all the way up to the nipple itself. So on the left, that first slide is what a standard or a total mastectomy looks like. There's nothing left on the breast, it's just flat to the chest. That gives you the lowest risk. Most of the time, you don't have to do radiation with that in an early cancer. Again, later, we may have to do other things still. But certainly for an early cancer, this may be all you need is the mastectomy. Well, the good news is now we have better options for reconstruction. So there's different ways to remake the breast and again, restore cosmetically what we had to take away for treatment. So there's two options. We can do a skin sparing, where we again still take the nipple out because there's breast tissue behind the nipple, but we save the majority of the skin, and then we can either replace that with body tissue, it involves a lot more surgery, or more commonly these days with certain types of implant. And that middle picture shows you how well it can look, and it can actually look very similar to your own breast. And so you do not have to do a double. Although some people do choose that, but you can see in this situation, this particular patient only chose to do it on the left, and you can barely tell that she had any difference between the two breasts. So, and we can also make you a new nipple, either cosmetically or through tattooing, either physically or through tattooing. And then we even have the option these days of doing a nipple sparing in the right circumstance, where we actually even save the nipple if you want us to. It does present a little bit of a risk because obviously there's, again, breast tissue behind the nipple, but for the most part, that risk is so small, we can actually keep your natural looking nipple. Again, giving you an even better cosmetic result should you desire that. So having a small cancer, meaning that we found it early through screening, gives us these options, even if you decide the mastectomy is the better option for you. We can still do a better job, cosmetically speaking, and we can hide the scars even better. And not all the pictures are here, but there are other options to make it even look better with the scarring. Next slide, please. We also then, with breast cancer treatment, one of the things that we always have to know is it involving the lymph nodes yet? Now, yes, we can do a lot with imaging, and imaging can give us a clue whether or not it looks like it's in the lymph nodes, but ultimately you have to take the lymph nodes out to look at them under the microscope to really know for sure. So in early stages of breast cancer, again, early diagnosis, we don't have to remove all the lymph nodes. There are three sort of layers of lymph nodes. If you see on the bottom picture, they're sort of on the right, there's three colors. There's a purple, a green, and a blue. That represent the three different layers of lymph nodes that cancer can go to, purple being the most superficial, green is sort of in the middle, and the blue is basically tucked behind nerves that I would have to cut, nerves to your arm that obviously we don't want to cut and we want to save. So we usually don't even look at the light blue lymph nodes. But the first two, the purple and the green, we can access. And traditionally, we used to take them both. That's called an after dissection. And we basically strip all those lymph nodes out to see if there's any cancer in them. But we don't have to do that if you have early stage. The top one shows that if you have early stage cancer, we can just take out a couple of lymph nodes rather than all of them. And these, again, correspond to the purple layer. And the risk of causing arm swelling or other nerve issues would be a lot less. And so your chances of having problems after surgery would be a lot less if your cancer was diagnosed early and we don't have to remove all the lymph nodes. So even your treatment would be better if we could actually find those cancers while it's in the stage, only detectable on imaging, not even something that we can see or feel. Now, it doesn't mean that, if we see it or feel it, that you don't have options. We can still do all of these surgery options that we just talked about. It's just that obviously the bigger the cancer, the more advanced the cancer, the more cancer that's there, the more we're going to have to do, and the higher your risk of having problems. So definitely screening allows us to be able to offer you better. Next slide, please. So I'm going to stop there at the end of surgery, and I'm going to pass the baton to Dr. Leach. I hope he's on with us now, and he will give you some more information about other things that we can offer you for treatment. Thank you.
Thank you so much, Dr. Chu. That was so much information, helpful information. I've learned so much myself. I think Dr. Benjamin is here.
Can you hear me?
Hi, there you go.
Hey there.
Good to see you. Let me spotlight you for everyone. Okay. Oh. Okay, I got you on there. I got both of the doctors on there. Okay.
Oh.
Here we go. Let me see. Maybe I can move Dr. Chu's light. Okay. Perfect. Okay. Did you want to share your screen, Dr. Leach?
You know what? If the prior PowerPoint, if you could load that, it should have my slides attached to the end of it.
Yes. Okay. So I can go ahead and share my screen.
Sure.
Again. Let me.
That was a wonderful talk, Dr. Chu. Thank you.
Thanks. I hope I didn't take up too much of your time, but I thought I would kind of do a little bit of stretch to give you time.
I appreciate that. I appreciate that.
There we go.
Okay, wonderful. So I'm Ben Leach. I'm a medical oncologist, and my role is treating breast cancer when it's been identified. So I think what Dr. Chu talked with you all about screening is really critically important. I'm going to talk about some of the treatments, and I'm going to give you a little bit of an overview. I don't want to overload you. There are so many treatments nowadays for breast cancer. It's a multidisciplinary strategy for treating people with breast cancer. Dr. Chu spoke briefly about surgery, so I'm not really going to touch on that, but that's obviously one of the most critical parts of treatment. I'm going to review with you some of the other therapies that are used, such as medical therapies or radiation therapies that can be used to treat breast cancer. So can you go to the next slide? So here I've just listed for you sort of a way to think about how do we treat breast cancer generally. Well, as Dr. Chu mentioned, surgery is a major component. We also have chemotherapy, which I'll talk about. There's radiation therapy. We have something called targeted therapy, which is kind of similar to chemotherapy, but not quite the same. And we'll talk about how those differ. We have hormone therapy. Many of you may have heard of hormone therapy. And then nowadays we have some new treatments that are starting to roll out called immunotherapy. And so we'll dive into that. And I like this picture here. It sort of shows you that the therapies can be thought of as a local therapy targeted specifically at the cancer itself. So targeted at the breast itself, that would be like surgery or radiation, where a beam of energy is targeted directly at the cancer, or a more systemic therapy like these ones listed here, like chemotherapy or hormone therapy. Those systemic means that those treatments circulate throughout your entire body, and so they work to fight the cancer wherever it could possibly be, or prevent cancer from developing at other places in your body in the future. Next slide, please. Okay, so just as an overview, I just want to remind you, what is cancer, right? So sometimes I start talking to patients and they ask me, what even is cancer? And it's an important question. Cancer is really just normal cells in your body that are going a little crazy and out of control. So on the left side, I think it's probably your left side of your screen here, you see a normal cell grows by dividing into the into the other cells, and it divides, you know, 1 into 2, and then the 2 into 4. Cancer cells start dividing and growing like crazy, and they're totally unregulated, and they cause lots of problems because they're growing, they create masses, tumors, and that's what we then see, and Dr. Chu might remove, for example. And so the reason that's important is because we use chemotherapy to target these cancer cells, and we take advantage of the fact that the cancer cells are growing very, very quickly. So chemotherapy essentially works by targeting cells that are growing and dividing very rapidly in your body. Normally in your body, you have cells constantly growing and changing, but when you have a cancer, it's growing very quickly, and therefore the chemotherapy targets those cells. Down here on the bottom of this picture, you can kind of see the chemotherapy going into the cancer cells. And without getting too far into the science behind this, because it's actually something that's quite complicated, the main way that chemotherapy works is by affecting the cancer cell's DNA. The DNA is the blueprint for your cell, for how to grow, divide, for how to run all the important activities that need to be done in your body. The DNA provides that blueprint, and the chemotherapy drugs destroy or affect that DNA so that the cell dies. That's how chemotherapy works. There's many different types of chemotherapy for breast cancer, and chemotherapy is often used in conjunction with other therapies. So for example, targeted therapy or hormone therapy, you may be using them together to fight breast cancer. Chemotherapy is sometimes used before surgery to shrink down a tumor really nicely so that when Dr. Chu does surgery, it's easier to remove, or she could do maybe a lumpectomy instead of a big mastectomy. So it can be used in a number of different settings, and it's always really contingent on the person and the situation that they have that we make a decision about how to incorporate and use chemotherapy. What's the problem with chemotherapy? Well, it's a poison to the DNA, and it doesn't just affect the cancer cells, unfortunately. It can affect some normal cells. So that's why you see people on chemotherapy experiencing things like nausea, diarrhea, hair loss. It turns out these are the other cells in your body that are growing relatively quickly, and as a result, they are also susceptible to some degree to chemotherapy. And so people end up having a lot of digestive problems on chemotherapy. Your hair can often fall out, and we have to manage these side effects. So there's always this balance between, you know, we want to give enough chemotherapy to attack the cancer and effectively kill it, but on the other hand, we don't want to hurt the person who's receiving the chemotherapy. So we have to be very cautious about that. We can go to the next slide, I think. How's chemotherapy given? It's usually given intravenously. So for example, you can see on the top here, there's an IV bag. The pharmacist would prepare the chemotherapy there. It's administered through an IV in your arm, and then a nurse who's certified in administering chemotherapy monitors you. This is one form of chemotherapy. There's actually also oral chemotherapy, pill form chemotherapy. Depending on the situation of a patient and the type of problem they have, may call for a different type of infusion or oral administration. So it just depends on the situation. But either way, whether it's given orally or intravenously, the medicine travels throughout your bloodstream ultimately. And so it goes throughout the entire body to fight the cancer. So not only does it go to the breast, presumably where we want to kill off any cancer cells that are in the breast, but if God forbid the cancer had spread to your bones or to your lungs or another part of your body, this would be an effective tool to try and fight it there. Next slide. Now, one of the things that's really critical about breast cancer is subtypes of breast cancer. And there's these things called receptors. And all breast cancer, when it's diagnosed, is tested for their receptors. So you may have heard terms like hormone positive cancer or triple negative cancer. These are terms that we use to describe the receptor status of the breast cancer cells. So on the bottom right there, you see there's a cell and it has these little receptors. They're like little fingers that are sticking out of the cell. And the receptors bind to things floating around in their environment and then use that as a signal to grow. In a cancerous breast cell, sometimes what happens is many of these receptors are on the surface. So you can see in the picture on the right there that there's a whole bunch of those little receptors, possibly more than you should normally see. And as a result, they're able to bind to more stuff in the environment, which gives the cell a signal to grow faster. Well, what are these receptors? Typically, there's 3 types of receptors. There's an estrogen receptor, there's a progesterone receptor, and there's a HER2 receptor. So in that little diagram on the left, I sort of showed you that there's PR, which is progesterone, ER, which is estrogen. Those are hormones. And when those are positive, we call it hormone positive breast cancer. And so when you have your breast cancer diagnosed, the pathologist tests for these receptors and they issue a report. And then we would be able to tell you, is your breast cancer hormone positive or hormone negative? And if it has a positivity for either progesterone or estrogen or both, that would be considered hormone positive. Another receptor that's tested for is HER2. And that's a growth receptor. That's not a hormone so much as a growth receptor. And that's important, you'll see later, for treatment because we have a medicine that specifically targets that. If the breast cancer has no receptors on it, meaning it doesn't have progesterone, it doesn't have estrogen, and it doesn't have HER2, it has basically none of these little receptors on the surface, that's what we call triple negative. Just again, because of the 3 receptor choices, all of them are negative. Triple negative breast cancer is a more aggressive type of breast cancer that can be a little more challenging to treat because we have a lot of medicines that target these other receptors and less that target something that's triple negative. So when someone's diagnosed with breast cancer, one of the most critical things to know is receptor status. And so when we talk with patients, we often will tell them you have hormone positive breast cancer, for example, or you have a triple negative breast cancer. And that's because it's critically important for the treatment choice and for prognosis. I would say about 2/3 of breast cancer, roughly, maybe a little more, are hormone positive, and about 10 to 15% are triple negative. And then in between there is a mix of some people that are hormone negative, but HER2 positive. So there's a mix, but most breast cancers are hormone positive. This is a challenging thing to understand, and I'd encourage you, if you ever are diagnosed with breast cancer, this is something you would want to spend a lot of time talking with your oncologist about, so you can feel comfortable knowing why certain treatments are being recommended and how they're going to impact the breast cancer. Go to the next slide, please. So let's talk about hormone positive breast cancer specifically. So there's a few drugs I listed here on the left, and one of them you may have heard of, I think is probably most commonly known as tamoxifen. But there's these other drugs as well, Arimidex, Aromasin, Femara, and of course, they all have their generic names, which I put there as well. These drugs essentially work by either blocking production of hormones or blocking the interaction of the hormone with the breast cancer. So there's this rather somewhat complicated picture here, but the idea is that instead of hormones being able to bind to the breast cancer and tell it to grow, we give these medicines that either interfere with that interaction or that literally decrease the production of hormones. So for some women, we recommend tamoxifen. For others, we recommend Arimidex. It's based on a number of things, mostly menopause status, but also we take into a number of other things into account. And of course, we talk with the patient. These medicines have side effects. We're affecting your hormonal status in your body. So of course, they can cause things like menopause type symptoms like hot flashes and joint pains, and that can be a challenge. So this is one of the things that we have to work on, figuring out what hormone treatment is best for each patient. And this is, again, is only used when the breast cancer is found to be hormone positive. So it would not be something we'd use, for example, in a triple negative breast cancer setting. We could go to the next slide. And then I mentioned there's this thing called targeted therapy, and this is very similar in a lot of ways to the hormone therapy because it involves targeting receptors on the cancer cells. So there's this very famous drug that was developed probably in the late 90s and came out early 2000s called Herceptin. And since then, there's been development of a number of other drugs, Perjeta, Kadcyla, and there's actually even a couple new ones now. They're developed specifically to target the HER2 receptor. So remember, there's those 3 receptors we mentioned. 2 of them are hormone receptors. That's the estrogen and progesterone receptor. And 1 of them is a HER2 receptor. So these drugs target that HER2 receptor, and they do it. It's very similar concept to what we just showed you with the hormone therapy, which is they block the interaction between the receptor and the protein in the environment so that the cell cannot grow. And as a result, the cells then usually die. This has been a huge, huge advance for breast cancer treatment. It used to be in the past, in the 90s, before I was practicing, that people with HER2 breast cancer actually had a worse prognosis because we didn't really have anything to target that receptor. Fortunately, these drugs were developed. Herceptin was really developed here in Los Angeles at UCLA. And now the prognosis for this type of breast cancer has changed dramatically. Dr. Chu and myself, I can think of several patients, offhand who we've treated with this medicine before surgery, and it's literally caused their breast cancer to basically disappear completely. It can be really wonderful and miraculous, and it can make it then so surgery is a lot less invasive. Perhaps instead of a mastectomy, a lumpectomy might be done. So it's really been a wonderful advance. It's also used if, God forbid, someone develops metastatic cancer where the cancer is spread to other parts of your body. These drugs can be used in that setting as well. And we've had some women have really wonderful responses to them. They're administered similarly to chemotherapy. So I put a picture there on the top. It's in the office through the IV. The drug travels throughout your whole body to fight the cancer in where we know it is, but also to hopefully kill off any microscopic cancer cells. Go to the next slide, please. And then I just wanted to touch base on this because this is a really super active area of research that's just started to enter into the breast cancer realm, is immunotherapy. I'm certain you've seen the commercials for Opdivo. That this is a really hot topic in cancer treatment. It's a new style of treating cancer that's different from chemotherapy or different from targeted therapy. The way this immunotherapy works is it's also an IV medicine given in the same way that chemotherapy or targeted therapy is administered. But instead of going after the cancer cells and trying to kill the cancer cells, it essentially helps your own immune system go and fight the cancer. So it's a totally different mechanism, how it works. It's been revolutionary for a lot of cancers. It's just now starting to be figured out, how do we use this for breast cancer? So every cancer is different. Breast cancer is different from skin cancer, is different from lung cancer. So even though something may work with one type of cancer, it doesn't always mean it works with the other. It's been a little bit of a challenge figuring out, how can we incorporate using immunotherapy and patients' own immune systems to fight the cancer. There's starting to be some clinical evidence that it works for people with triple negative breast cancer. And we're hoping that it's going to be something that we can also start using in other types of breast cancer, maybe hormone positive breast cancer. But this is a very active area of research. Next slide, please. And then I'll just touch base on this briefly, because this isn't actually, this is a different specialist who we get involved for radiation treatment. Radiation treatment is a targeted treatment that uses essentially light energy to attack the tissue and kill off microscopic cancer cells. It's most often used after someone has had surgery. So for example, if Dr. Chu performed a lumpectomy, typically a patient would have radiation afterwards to help eradicate any remaining microscopic cancer cells that could be left behind. It can also be used for people who have advanced stage cancer. If, God forbid, a cancer spread to someone's bones and was causing pain, you can use radiation therapy to zap that area to control the pain. It's a complicated procedure in itself. You can see here, there's a picture. This is a CT scan picture, the black diagram there. It's sort of a cross-sectional image of someone's body. And it's amazing how much physics and planning goes into developing a strategy for delivering radiation therapy, which is why I mentioned it's a specialty in and of itself. And I'm just talking about something called photon therapy, but there's also multiple other types of radiation therapy that sometimes can be used. One active area, just to give you an idea, is something called brachytherapy, where therapy is done through seeds that are implanted. There's many different things that can be done here, but this is the one that's most commonly used and the one you would see most often, this type of external therapy where you have a machine that's delivering radiation externally from the outside. I think that's most of my slides. I'm not sure if I have another one there. I tried to go fast there. I know that was a tremendous amount of information, but I wanted to give you sort of an overview of what the treatments are like, what options are available. When someone's diagnosed with breast cancer, obviously we sit down together and talk about all these different options. Dr. Chu and I work together frequently talking about what's the best strategy. Is it chemo and then surgery and then radiation? How do we structure the treatment? And there's a lot of important clinical evidence we use to make those kinds of decisions, in addition to talking with obviously the patient who's being treated. So it's a process, it's multidisciplinary. And thank God things have advanced quite a lot. Even in just the last 20 years, I'm optimistic that things will continue to improve as far as treatment strategies over the next 20. So thank you so much for your time and appreciate your attention.
Thank you so much, Dr. Chu, Dr. Leach. Thank you so much, Amanda. Thank you so much for your presentation and just being here with us today. Does any of the attendees have any questions for Dr. Chu or for Dr. Leach? You can raise your hand. There's a function at the bottom part of the page of the screen where you can select to raise your hand and you can verbally ask the doctors some questions, or you can, if you feel more comfortable putting them into the chat box, you can do that. But we'll give a couple seconds for you guys to do that if you have a question.
And I just wanted to kind of piggyback on what Dr. Leach said about breast cancer treatment really is multidisciplinary. I think the key here, I hope that we've given you an idea of, is that there are a lot of options. And what's wonderful nowadays is that we're able to tailor it for the most part to the individual patient. So there is no one size fits all. There's no, I mean, there's a standard treatment, meaning that there are obviously guidelines to help us make the decision and with you as the patient. But the point is that there's all sorts of ways that we mix and match these kinds of treatment options to come up with the best plan for you. So, so it really requires a lot of close relationships and a lot of close working time between the patient and your team of doctors, and also your team of doctors talking to each other. So, and I think that's where for breast, it's really made some tremendous strides on what we can do for patients now and the successes that we've obtained.
Well, I don't see any questions in the question and answers section. I put the telephone number, the main number for City of Hope in there. If you have any questions or you want to just get connected and learn a little bit more, you can also call us at ONEgeneration if you have any questions about our services or just kind of to review this recording today, because we will have that connected into our newsletter. So we can definitely get you signed up, and then that way you can watch it over and over and you can share it with family members. So there was so much helpful information from my biology background. I'm like, I love all of this talk. So it's really, really, really helpful. And I hope you guys got some helpful information, and please share with your family members and for yourselves. But like I said, you can please reach out to us at any time. Thank you so much, Amanda, Dr. Chu, Dr. Leach. Thank you so much for your time.
Thank you.
You guys.
Thank you all. Thank you so much for inviting us. Thank you.
Yes, thank you for having us. Have a wonderful day.
Have a great day. Bye.
Bye-bye.
Everyone.